So a very good afternoon to everyone. We are back from our short lunch break. I'm really sorry, but after that you can have a good dinner. So we'll go into our next topic, which is mostly on recent advances. And we have a very interesting speaker and an interesting topic. So our interesting speaker is Dr. Kyati. So Dr. Kyati is she did a sports medicine specialty in Vardhaman in VMC Safdarjung, and she is an international pole vaulter, so an athlete turned doctor, which most of us are, but still who has gone and represented India. She has been seven-time Indian national champion. She has gone for Asian indoor and outdoor championship. She is now IAF certified level 1 youth athletic coach, and she's an SR in VMMC, also teaching. So so we thought of doing a little bit different topic this time. It's on it's on transgender in sports and what we need to understand in current guidelines. So I'll be sharing as usual, since we have always have some technical issues. And if you have got, so I'm just leaving the floor to Kathy to start. You can see the presentation, right?
Yes, sir.
Yeah. So just tell me next. I'll keep it. So the floor is on to you. Yeah.
Just 1 second, sir. I just am having some issues just minimizing this on my screen.
Yeah.
Yes, sir. Can I
Yeah.
start now?
Yeah. Please do.
Thank you, sir, for inviting me to speak here, and I'm really humbled by the introduction, and I'm really glad to be a part of ISSEM and glad to be a part of this. So today we're going to speak about transgender and DSD in sport. This is a very untouched topic. Somehow there is not much about our role as sports physicians in this aspect. So I think it's good that we should know about the guidelines and touch up upon what it actually means, what is our role in this, and what are the things that we should do and we shouldn't do. So to the next slide, sir. So usually when the Olympic sport started, it started with just one category, which was the men's category. Slowly, there was introduction of the women athletes into the sport, and sport has been divided into just the men and the women aspect for since the women category had been introduced. Now the issue is, sir, can you press enter? Yeah. So now the issue comes with, do you look at the gender? Do you look at it as a spectrum? Is it just male, female? Is it binary? Is it a spectrum? So our understanding about that is still evolving. And here comes in the aspect of transgender athletes. So now, where do you place a transgender athlete? Do you place them in the women category? Do they play in the men category? Should they be, a special category made just for them? So these are the issues that sport even today is facing. So we'll be talking about some of the athletes. So Rebecca Quinn, she is a transgender athlete, football player from Canada, and she is the first transgender athlete to take part in football in a women's team, and having won the gold medal at the Tokyo Olympics. So this is one of the stories that was highlighted about transgender athletes. Going on to the next transgender athletes, we have Leah Thomas. So Leah Thomas was assigned male at birth. So grew up as a male, was a swimmer, and once he reached puberty at around high school, he started to identify himself as a female. So during that phase, he started to take hormone replacement therapy and transitioned into the women's category. Now there was a lot of uproar about, how, whether this should be allowed, whether it is right. So what are the guidelines? And at that point, when he changed the identity, she then came to be known as Leah Thomas. She won the NCAA Division One swimming championship, and was then banned from taking part in the Olympics because there was no category that would fit her. Going on to the next athlete, we have Caster Semenya. And Caster Semenya has been in controversy for such a long time. She is a two times 800-meter world Olympic medalist, Olympic gold medalist, three-time world championship medalist. And she faced a series of controversy and underwent from case to case at CAS. Now she's fighting in the Swiss court about having to take part. Like, she wants to take part at the highest level of sport and has been denied that opportunity to do that. So she's been fighting human rights. She's been fighting that she should be allowed to participate at the highest level. Then coming to Duti Chand, she is our Indian Olympian over the 60 meters and 100 200 meters. And in 2014, just before the Commonwealth Games, she was denied opportunity to participate in the Commonwealth Games in view of her hyperandrogenism. And at that point, she went to Court of Arbitration of Sport, which is the CAS. And after the whole legal hearing, she won the case, and she came back in 2017 to win the Asian Indoor Championship. Now, after that, right now, she is in a controversy where she's under a doping case. But this whole thing, we are still fighting controversy after controversy, and where we stand today is what we are going to discuss now. Some of the terms that we need to know is, what is transgender? Transgender means that the person can be male or female identified at birth, but he or she identifies herself. Now supposing they are they are male at birth, the biological sex is male, but they identify themselves as female, or they are biologically female at birth and then identify themselves as male. So this is transgender. Now, what is differences in sexual development, so which is the DSD? Now DSD is, they are born as female or intersex at birth, and they identify themselves as females. But what happens is, instead of having ovaries, they have internal testes. So these are the other group of athletes that you are dealing with. So there's a transgender is a different thing. The differences in sexual development is a different thing. Intersex is the term that is used commonly. It's not a medical term. It is used commonly where there is a difference between the genotype and the phenotype of the person, or they can be a total ambiguity. So it's a kind of like a blanket term that is used. And sexual orientation is what you are attracted to. So these are the four terms that one should be very clear about. Moving on to intersex Olympians. Now intersex, as I told you, is a very blanket term. In this shows the number of Olympians from different countries, and as you can see, India, there was one Olympian, that is Duti Chand. Similarly, when it is divided sport wise, we see that athletics has one of the highest number of transgender athletes taking part, followed by boxing, and then we have football and swimming. Moving a little about the history, about we go back in time and we'll see how all of this started. So during the during 1936, there was visual verification. So they said, if you want to take part in female categorization, then they have to visually inspect the person and say that they are female, and then they allow them to play. So in 1966, there was like a nude parade where a panel of doctors would sit, and all the athletes who would take part in the female category would have to undress and confirm that they are female before they had to participate. Now this was stopped because of the protests, that this was very demeaning for female athletes to have to undress in front of a panel of doctors. Then came then they moved on to the chromosome. Now in the chromosome testing, so they said that if there is a bar body, so now supposing you have two X chromosomes, so one X chromosome would be active and would form a bar body. So they said if you have a bar body that is present in your buccal smear when they take the this DNA, if you have the bar body, then you are female. If you are not, then you are male. Then came in the controversy that what happens if it is a 47XXY? They would have a bar body and still be male. And what happens if it is a 45XO? Then you don't have the other X chromosome. So in turn, you don't have a bar body, but you're still female. So then they said that, okay, this is not going to work. Then came in the thing about the SRY gene. Can you go to the next slide? Then coming to the SRY gene. So then they started doing the PCR testing, and they said that if there is an SRY gene, then you are male, and then if you don't have an SRY gene, you are categorized into the female category. But then what happens to females who have a translocation of the SRY, or a male which has a deletion of SRY? Then they realized that this genetic testing is no longer working, and the IOC banned the routine the sex testing. Then came a time where they said that we will do it on case to case basis. If there is any doubt in a certain athlete, then they will have to undergo a gynecological, endocrine, and a psychological evaluation, and then the case will be taken up. In this, there were two athletes. One was Shanti, an Indian athlete who was a quarter miler, and Caster Semenya. Both of them got stuck in this whole multidisciplinary testing. And later, now Caster Semenya, as we know, is still fighting her case. Now, what is the issue? So the issue is, if you have a higher testosterone level, you basically have an unfair advantage, that you have more muscle, you have more amount of blood, you have more hemoglobin, and you have more bone growth. So this is an unfair advantage to people who, whether exogenously or endogenously, have higher testosterone levels. Now what happens is, if this is the advantage, somebody goes through testosterone suppression treatment, and then they reduce all of this, but say they've achieved puberty, their frame is still, the bone growth is still going to be that much, they're okay, they're going to lose their muscle mass. So is there an advantage or a disadvantage? So there's a controversy over that okay, if they still have a bigger frame on their and bone growth, and they have lesser amount of muscle mass to support it, then it's a disadvantage. So this controversy is still going on. And then the IAAF, which is now called as the World Athletics, the International Federation, they said that their serum testosterone level should be less than 10 nanomole per liter to participate in the female categorization, whether you do it with some surgical treatment or whether you take some hormone replacement therapy. So coming next to the Duti Chand case. So when Duti Chand filed a complaint in the Court of Arbitration of Sport, her evidence was, her appeal was that there is no evidence that there is a positive relationship between the testosterone level and the athletic performance. There is no dose response relationship that you can say, if you increase your testosterone level by 1 nanomole, this much is the performance increment. So there was no evidence, there was no study done as such. So, and then she said that, her lawyer said that excluding an athlete just based on something that is naturally produced by her body is not right. And if this is the case, that testosterone causes increase in performance, why doesn't why is it not shown in like the male athletes who have higher testosterone or lower testosterone? They don't have too much of a difference in their performance. So after this, when Duti Chand won the case, and World Athletics had to revise its guidelines in 2018, when the IAAF, as it was called before, they said if you are wanting to take part in female category from 400 meters to 1 mile running, then your serum testosterone levels should be below 5, and you should continue to have that for 6 months, and in order to participate in this category. Then they realized that there are other events as well, like the heptathlon and different events, which also has an advantage because of the higher serum testosterone levels. By then, World Athletics had published a paper. I had not put it in this, but I can share it with you. So they published a paper saying, showing that the serum testosterone levels of a lot of Olympic athletes, they took their blood samples in the Olympics, and they gave out a paper saying this was their performance, and there were certain events that showed a definitive increase in the performance. So once this was done, they revised their guidelines, and now there are some questions that we need to address, and that's in the next slide. So initially when sex testing started, it was just to exclude the male imposters, but now it has shifted to protecting the women's sport and fair play. So what are the questions that need to be addressed? Is there a difference between the endogenous testosterone one produces and the exogenous that they take? Is there a dose response relationship between the testosterone? How do you explain when there is an athlete who has androgen insensitivity but still has higher testosterone levels and is performing well? And why doesn't it apply to the male athletes when their testosterone levels are not at the same level? So these are the questions that need to be answered. And when we say that, an athlete like Michael Phelps, when he is genetically gifted, he is not eliminated from the competition. But when a transgender athlete is self gifted with a higher androgen level, then, we are eliminating that athlete. So recently, we also had the controversy of Swapna Burman, who finished fourth in the Asian Games. Her teammate Nandini, who finished third in the heptathlon, she said, I lost my bronze medal to a transgender athlete, and that, this she wants her medal back. So sometimes, being in that position, it could feel like you are, just because there is a person who has an advantage and is winning while you have put in the same or more effort into, going into that meet and playing. So after this, World Athletics came up with the current guidelines, which is from 2023 March. They said that if you are a transgender athlete and you want to take part in female categorization, you have to give a written or signed declaration that your gender identity is female, and that you have not experienced any, and according to when they test, there is no male puberty that is beyond Tanner stage 2. They will maintain a serum testosterone level below 2.5 nanomole per liters, and they will do so until unless they continue to compete at any World Athletics recognized event. So this is the transgender. Now coming to the DSD. Now DSD, so if you want to take part in female categorization in any of the world ranking competition, you have to legally be recognized as female or intersex, and you must have your testosterone levels below 2.5 nanomole, and you have to continue to keep that as long as you wish to compete. Now in a DSD, the only thing is, yes, you can have higher testosterone levels, but the other criteria is that you should be androgen sensitive to that high testosterone. So there are 5 recognized DSDs that are which are targeted, and these, if any of the diagnosis of the athlete falls into these 5 categories, then they have to undergo any further medical or surgical treatment to continue to take part, basically lower the testosterone level. But World Athletics, for legal reason, does not force any of the athletes to undergo any kind of treatment. It is up to the athlete. But if their serum testosterone levels are not below that level, then they are not allowed to participate. Similarly, FINA, the Federation of International Aquatics, came up with the guidelines, which said that, if you are a transgender athlete wanting to take part in the female categorization, so, or if you have previously taken testosterone as a part of, the male to female gender transition, then you should have taken that for less than a year, and the anabolic effects of the testosterone that you took should have been eliminated by the time you want to compete. For transgender women, they said that you have to be completely androgen insensitive, and if you are androgen sensitive, your male puberty should at the beginning should be Tanner stage 2 or less before the age of 12. So the serum testosterone levels below 2.5 has been taken up as a guideline for even for FIFA, for FINA, and World Athletics. So if the basic thing right now would be there is a transgender athlete wants to take part in female categorization, then the baseline is get the testosterone levels to less than 2.5. Now the issue with implementing all of these guidelines is one of the biggest thing would be human rights. Now, can you go to the next slide? So, discriminating based on gender or sex is a violation of human rights. Enduring any degrading treatment just because, you're naturally a certain way is not right. And also, the other thing is interference in the privacy, and anything that attacks the honor and reputation is taken as a bad thing. So, human rights is an issue. The other issues that we should know as sports physicians is the medical issues. Now, if there is a transgender athlete, can you go to the next slide? If there's a transgender athlete and yeah, so is coming with amenorrhea, is coming with infertility, counseling them, what are the long term risk health implications. They could develop testicular cancer. If they still have testicles in their abdomen, then that could be cancerous. What is endocrine psychological counseling for them, education about the basics, that what is uh, the issue that they're facing, why are they facing it, and how it affects their own body, their future life. The other thing is trust and sensitivity. One of the biggest thing is maintaining confidentiality, because once any of this comes out in the media, it's just made such a big deal that they tested her sex, or they're questioning her gender. So being very empathic and sensitive towards the athlete who may be DSD, who may be transgender, and the ethics. One of the things is the IOC says that if there is an athlete in your team that would be investigated or disqualified under being hyperandrogenic, then the team physician can also be sanctioned. So this is something that, if anybody is going out with the team as a team physician, so this is something that you need to be aware of, that even you can be sanctioned if you overlook a transgender athlete competing, or a DSD athlete, and you don't have their testosterone levels measured. So I'm going to end my talk with this, and I'm open to any questions that maybe something that you want to know.
Thank you, Dr. Kyati. That was a wonderful talk where you have gone in detail about transgender and DSD. This is a much needed topic which has not been explored much in sports medicine, and I don't think many people have. They've just read about it, in the news, and getting information, but nothing in detail. So thank you, Dr. Kyati. Please do stay at the end, because we'll be asking questions at the end of the session after the two speakers. So I'll go to our next speaker, Dr. Sneha. Is Dr. Sneha here? Just 1 second. Yeah, Dr. Sneha will be joining us soon. Some internet issue from her end. Before that, I'll just speak a little bit about her. Dr. Sneha is a sports dentist and nutritionist. She's the director of Dental Fitness and Polyclinic in Pune. She has done a fellowship in aesthetic dentistry and master's program in sports science and nutrition. She's one of the pioneers of sports dentistry in India, and she's been a faculty of in development and diploma in sports dentistry, IST Pune. She's also a consultant sports dentist at VMAX High Performance Center and many sports in schools, sports clubs, etc., all around Pune and Maharashtra. Um, she is also the founder and director of the National Sports Dentistry Committee, which comes under the Indian Society of Sports and Exercise Medicine. So she will be talking about the sports dentistry. What is the missing link? Usually, what we do is that we always immediately we think sports dentistry is linked with um, trauma. So there's nothing more than that, or we just think. So she will be dealing with other aspects as well, and how sports dentistry plays a major role. So just give us a few minutes. She'll be joining soon. She has some internet issue in the last minute that has just happened now. Hi, Dr. Sneha. Dr. Sneha, you're muted. I'll just please unmute yourself. Just 1 minute. You're still muted.
Hello, can you
Yeah,
hear me?
yeah, I can hear you now. So can you?
Okay.
I've already given a brief introduction about yourself already. So if you can start sharing your
Okay.
slides and we can start with you.
Yeah, I'll start sharing. No problem. Just give me a minute.
Yes.
Can you see your screen?
No, we cannot see.
Hello.
Yeah. Slowly it's coming. I can't see the slides. It's just a dark screen right now. Yeah, it's come.
So, huh. And can you see the slides moving?
Yeah, it started moving. Yeah. It's not very clear, but your internet is, I think, a
Fine.
little bit slow. Yeah. You can start, madam. You can start.
Okay. Yeah. Just tell me if if suddenly if the internet connection just goes, just give me a call or something,
Definitely.
or if it is too slow.
Yeah.
Okay. Yes. So, good afternoon, everyone. This is Dr. Sneha Divekar, and it's wonderful to be part of this ISSEM webinar. Where we are talking about different topics on sports medicine. And yes, sports dentistry indeed is one of the upcoming and important topics in sports medicine. And it is actually a missing link, can be said, in the athlete healthcare. So far, so good.
Yeah. So far, so good. No
Yeah.
problem. Please continue.
Okay. So, I'll go ahead with the presentation. Yeah, so we all know that in last 20 years, sports medicine in our country has contributed to healthier athletes with optimum fitness levels and good performance. Today, winning is now becoming more important than just participating. Basically, best or a high performance is the keyword today. We all know as sports medicine and sports science professionals that there can be a millisecond difference between winning and losing. That is why most stress today is placed on talent detection, research on all the aspects to improve athlete performance, and all professionals are included in the athlete healthcare team. Thus, sports medicine has now become a truly multidisciplinary field. So the sports medicine has various players on it, and today definitely dentists are one of them. So let us see what is sports dentistry.
Sports dentistry is the branch of dentistry dealing with prevention and treatments of the pathologies and injuries of the oral cavity and the stomatognathing system related to sports activities. But why is it so important? Now, there is a certain Dr. Rob Price who is head of medicine and performance at Leeds United. And he says that there is nothing more annoying than a player missing a game for a problem that was preventable or could have been treated earlier. That is why sports dentistry is more important, because sports dental care is preventable dental treatment most of the times. So let us go back and see the history of athletes and what all dental care has been taken till now. Let's go as back as in 1958. At the time, the dentist Mario Trigo traveled with the Brazilian soccer team. The World Cup lasted most of the month of June. During that time, Dr. Trigo pulled around 118 teeth from 30 different players. He also observed that the athletes who waited longer to diagnose, treat, and recover from their concussions were the same athletes with dental infections. Now, as a result of dental treatments for the Olympic athletes in Barcelona 1992, there was an increase of improvement in the psychological situation of these athletes and improvement of the muscle performance required. Then forward, the dental care at the Athens Olympics in 2004 was the second most searched service in the Olympics, behind only physiotherapy. Now, in Beijing Olympics in 2008, 80 dentists performed about 1600 dental treatments. So, I would like to stress here a little bit to say that eventually the type of the dental treatments have changed. Just from, if you notice, just from removal of the teeth to doing conservative treatments of the teeth, the type of the dental treatments has also changed, and the number of treatments that are performed on the athletes today is also increased. So there are a lot of studies that are being done on oral health and performance. So wherever the international games are held in whichever countries, dentists in those areas, they have taken some efforts to create dental literature. Like for example, in London 2012 Olympics, athletes were surveyed for their oral health. Okay, and the survey that the result of the survey was that 40% of the athletes were bothered by their dental health. 20% of the athletes felt it impacted their training and performance, and 30% of athletes reported a loss of quality of life. So you can understand this is the condition with international level athletes. So you can imagine what must be happening at the grassroots level. So thus dental literature is containing information from various surveys taken at various championship events that clearly demonstrate the need for basic dental care in athletes, which improves their quality of life and hence their performance. So we will just try to understand how exercise or sports and oral health are related. Now what happens because of exercise or playing continuously, there are some risks to the oral health. Now let's see what are these risks. Obviously, the first most important risk factor is a dental fracture or dental injury, which can happen either from sports components like rackets, floor, etc., or getting hit by the opponent. Bruxism. Bruxism is, clenching or continuous grinding of teeth is what is called. It can be common due to the stress that many athletes undergo. Xerostomia, better known locally as, in a layman's term, as dry mouth. It is the consequence of intense exercise and mouth breathing. It can lead to a variety of problems, and bad breath is definitely one of them, but a host of other problems it ensues. Caries. Now, the high sugar content of sports drinks, as well as the usual high carb-rich diet of athletes and decreased saliva from xerostomia, all these factors, see, normal people are also going to get their teeth decayed. That's obvious, but the percentage of athletes getting the higher chances of decay is way lot. Also, same happens because of enamel erosion. There is a lot of tooth sensitivity. Why is this happening? Is because the acidity of isotonic or energy and drinks and soft drinks consumed by the athletes is way more than the normal population. Also, teeth coming in contact with chlorine in case of recreational and competitive swimmers. So because of all these factors, the dentist has to keep all these factors in mind when the dental screenings of the athletes are done. And also, for all the sports science and sports medicine professionals, please understand this, that how bad oral health can affect the athletes overall health and performance. The systemic inflammation resulting from gum problems, now gum problems, it's proven that they can lead to various other problems like health diseases like cardiovascular problems, diabetes, etc. So what happens, these chronic gum issues, it may increase the risk of having other conditions, and this obviously could worsen the athletic performance. Malocclusion and bruxism. Now what happens because of bad bite or clenching? There is lot of overloading on the jaws and the muscles of the jaws and the jaw joint. Now this overload, or this leads to transfer of that load to the muscles of the neck and the back, and this leads to muscular contractions and spasms during the while the athlete is playing, and this can increase the chances of the athlete getting injured. And of course then it will affect the performance. Bacteremia results from oral infections. We all know that any kind of pus or swelling in the mouth, it is going to give you temperature, cause you fatigue. So all this kind of infections, it is again going, if it is going to cause fatigue, again it is going to affect the performance. Inadequate chewing, believe me, this can be this is very underrated topic. Inadequate chewing or problems in the oral cavity can lead to an inadequate chewing, slower digestion, and reduced energy power in athletes. So I mean, you all know that how important good digestion and good absorption of the nutrients is for the athlete. How much ever sports nutrition policies and principles we follow, but if the athlete is not able to properly assimilate it, it is not going to be of any use. And of course, any kind of dental injury or pain in the oral cavity, it is going to interfere with the athlete's performance, as it is going to affect the focus and concentration of the athlete while playing and also during training. Yes, so talking about dental pain, there are basically two types of pain: mucosal pain, or gum or cheek originating from the soft tissue. It can be stinging or burning sensation. Pain from dental origin can be either short, sharp, or dull and persistent. How it is going to affect the athletic performance? Now, if it is an acute or sudden pain, it will just abruptly lead to a stopping of any training or competition that the athlete is playing. Chronic pain, chronic, dull, aching, persistent pain, it can cause depression, anxiety, and it can lead to long-term effect on the athlete's mental health and performance. Yes, so all these factors are affected: the psychology, appearance and self-esteem, function, mastication and speech, social, intimacy and communication, pain, acute and chronic. So what is happening as a result of all this? It is interfering in athletes' daily life. How? This is the sequence: diet alteration, improper nutrition, sleep disturbances, self-medication, inability to train hard, and loss of confidence. And the most important thing, the dental pain is not going to go away on its own unless and until that tooth gets treated. Yes, so as I said earlier, xerostomia or dry mouth and other, it can cause fatigue and other bodily infections. So what common dry mouth complaints seen in athletes: thick, stringy saliva, halitosis, cervical caries, periodontal disease. What all infections can happen because of this? Opportunistic infections like oral candidiasis, mucosal aphtha, Fisher tongue, stomatodynia, herpes simplex. It's a huge list of oral infections. Also, as I said, periodontal disease can lead to other health problems like heart disease, cerebrovascular disease, respiratory problems, and preterm birth as well. Interestingly, one more finding has shown that in athletes with injured Achilles tendon, if the inflammation worsens, it increases the healing time and affects the training and performance. Now, one finding that has come across in some studies is that if the athlete patient is having recurring Achilles tendinosis, the athlete should consider a dental problem, because what is happening is, because of the continuous or untreated dental infection, See, the lymphatic system of the body is connected. I know what some people might think, that where are the teeth and where is the foot, but the lymphatic drainage system is connected, right? So because of what happens, lymphatic inflammatory complexes, they reach the tendinous area, and they don't let the inflammation heal. That is why, if you are a sports medicine professional, please consider the athlete for a dental checkup if the tendon is not healing. And if you are a dentist, then ask the athlete if there is any history of recurring Achilles tendinosis, if the athlete is diagnosed with chronic gum infections. Now, this is again very, very interesting and very upcoming topic in sports dentistry, in which there are three examples of how malocclusion or improper bite can result in impaired athletic performance. Now, this is an image which you will see, a computerized image, which reveals that how podal pressure is affecting like, if you will see, in 85% cases reveal that bad bite can lead to unequal force distribution in the athlete's feet. So this itself, improper bite is, there is a very, a lot of athletes are going to have this kind of some malformations. So correcting them, either the malformation has to be corrected, or wearing corrective dental trays or mouth guards during the play will improve the symmetry of running pattern and reduce the chances of injury. Now, also there are certain facial types. Studies reveal that flat, long facial types with incompetent lips, it can cause fatigue, insomnia, allergies, and of course, it will affect the performance. And of course, one very, very big topic that we cannot afford to miss out is the increase in dentofacial injuries in sports. Today, so many across India, so many contact sports are on the rise. So what is happening because of that? There is increase in dental injuries, much more than any other injuries that are same. So it is estimated that over 5 million teeth are damaged or lost each year in sports. An athlete has a 33% chance of sustaining a dental injury in sports. 80% of tooth injuries are obviously, to the maxillary central incisors or the two front teeth. Now, what is happening because of this? There is, as doctors, we know there is a physical impact. The tooth gets fractured. There are some facial fractures, and all those things we know. But along with that, there is a lot of psychosocial impact of these dentofacial injuries, especially if the face is also involved. It can lead to depression, anxiety, hostility in the athlete. It can lead to loss of self-confidence and image, reduced self-esteem. And now, problem, what happens if the symptoms are sub-threshold, if the athlete is not getting any proper help, then that can lead to poor intervention and rehabilitation of the athlete. So it is very important for this kind of PTSD syndromes, that the dentist and the sports medicine physician together, they need to, along with the psychologist, they need to help the athlete out of such kind of situations. Now, these are very, very simple examples, but I will tell you what happens, how the patient thinks. Nowadays, young children forget about professional athletes. These are young children who had come to me with broken teeth because they were not wearing mouth guards. They fell while playing. These kids, they have refused to go to school because of the dental trauma. Luckily, for in these 2-3 pictures, it was not a very complex trauma, but they refused to go to school. These were 13 to 14-year-old boys. Okay, so then this boy, the third picture, we did teeth cleaning for this young man. He was, I think, 21, 22-year-old athlete. So he was continuously complaining of yellow teeth, bad breath. His confidence was low. He was playing a team sport, and he was not comfortable because of all these things. So such small things are affecting the athlete mentally. So here, what we do is we get not only do their treatments, but along with them, we show, this is the example of a photo of an oral care kit. Where the athletes are going for various competitions. They are carrying so many things for themselves, protective guards and stuff like that. So they need to have an oral care kit with them, and these are the 2 to 3 types of mouth guards that are available. So you have to, if the athlete is playing the contact sport, you have to tell them, educate them about what type of different mouth guards are available in the market, what is best suitable for the athlete according to what type of sport and age they are in. Now, this was a very interesting athlete that I met few years back. She was a female national hockey player, and she shared her story with me. I really wish I could have, taken a video of her or recorded whatever she said. So, what she told me was that some days before a national event, she had a tooth problem which she ignored. And one day before the final match, the tooth developed severe pain and she took medicine, but it did not completely stop, and her performance got affected that day. And today, till date, she repents, doing that. So I keep telling this story to all the athletes and coaches and sports professionals that I know, that the only solution. See, now another problem in this case is there are so many drugs banned by WADA, and the latest one that has got banned is tramadol. Now the problem is that tramadol is one of the very effective painkillers in case of severe dental pain that we use. Okay, so now in this kind of situation, if the athlete comes to me, and then now I'm stuck because I'm not able to prescribe her or him this kind of painkiller, right? So the only solution for all these problems is preventable dental screenings and timely dental treatment, so that you don't land up in situations like this. So basically, to conclude, what I want to say is the mouth is the mirror of the body. Subtle effects on training and performance could conceivably be highly important in an environment in which aggregations of marginal gains is critical. Don't get baffled. हिंदी में उसको बोलते हैं कि हर छोटी चीज जरूरी है, head to toe. That's what is the meaning of this sentence. Okay, so basically, a athlete with a healthy mouth can eat a wide variety of food without discomfort, communicate with peers, concentrate well on the field, and can practice the sport of his or her choice without disruption. Right? So, और क्या चाहिए? This is what we want. So thus, I want to pass this message to as many healthcare professionals that, your friends who are dentists, if they are interested in becoming sports dentists, they must know the ways by which the dentist can intervene, to improve the oral and general health of the athlete, thereby helping in improving the athlete performance. The presence of dentist in the athlete support or healthcare staff is of paramount importance. This topic of sports dental care, it basically needs large scale awareness, so that the dentists, athletes, and the sports healthcare professionals realize the importance of neglected oral health of athlete, or the missing link for their better health and performance. Sometimes it can so happen, if you might realize that the athlete is, everything is good, but still something is holding back, right? So that is where the neglected oral health comes into play. So yes, I would like to end with this message. And before I end, I would just like to tell a few things about myself. So yes, I'm sure Dr. Unithan has introduced me. A few slides about what I do. So I am the head faculty of Diploma in Sports Dentistry here at ISST in Pune, the course certified by ISST and Dental Reach. We conduct many workshops and awareness lectures for dentists across the country on sports dentistry. I have been a local, regional, and national speaker on sports dentistry. I have conducted the first international level dental conference in India on sports dentistry, Dental Reach Regional Conference and Awards, in which I was not only I was a scientific chairperson, I was the keynote speaker, and we had a very, very interesting session in which we had a multidisciplinary symposium on sports dentistry with lectures from various other disciplines, where Dr. Kiran Kulkarni had also participated in it. So I was the panel talk moderator for that. I have been really lucky to be awarded by many organizations for leadership in sports dentistry and as a speaker on sports dentistry. Also, I have been a member of various sports organizations. Of course, I have been a life member of ISSEM since last 4 years, and I'm very happy that I have given an exclusive webinar on sports dentistry on ISSEM platform. That was, I think, 2 years back, and now this time again. So I really thank them from the bottom of my heart. I have been one of the first dentists to get featured on ISSEM website, and ISSEM has been our academic partner for our sports dentistry online international conference that took place in November 2022. I have been part of, I am rather a part of Association of Sports Nutrition and Fitness Science, and I've been the first sports dentist to be on their panel. I have my articles published on sports dental care on them, and I have been the first dentist to pursue a course on sports nutrition, which is approved by SNFS. Also here in Pune, we are having lots of various, sports related networking groups. So this is a group called Women in Sport India, where we attend networking meets. I have completed a master class with VZ. I have attended VZ mentoring program to develop all round understanding of sports. And I have been the first dentist to give a webinar on sports dental care exclusively for all our VZ members. Also, I'm a part of Sports Entrepreneur Foundations, where all science and sports management professionals, we meet regularly, we exchange information, we network. Everything is, for betterment and development for the athlete. And I'm extremely happy to let everyone know. I think many of you might be knowing already that on World Trauma Day on 17th October 2023, we announced the formation of National Sports Dentistry Committee under ISSEM, in which our mission is integration of sports dentistry into sports medicine, oral health and dental trauma care for Indian athletes at all levels. Basically, so we want to build a team dentists at all levels, city level, district level, state level, like that. And we want to educate and create awareness in athletes, parents, sports professionals, and even dentists. This is my core team of the National Sports Dentistry Committee, in which I am the founder and director. And on December 2023, we had a wonderful online inauguration program of our committee, where one of the most senior and renowned speakers of sports dentistry, who is practicing sports dentistry in 30 years, Dr. Steve Mills, he was our speaker, and our Dr. Kiran Kulkarni, ISSEM core team member, was our guest of honor as well. And we received an amazing response for this inauguration program, and a lot of people are interested in knowing more about this. So yes, I would like to tell here that we are open for membership, and any dentist interested, any of your friends, please give them my contact details. We will let you know more about it. So to end, it is said that prevention is better than cure. In the same way, sports dentistry is better than avoidable dentofacial rehab of athlete. So, dear sport professionals, if you are in Pune or based in any other city, kindly refer your athlete, patients, or athletes in your friends or family circle for oral health assessments, customized mouth guard fabrications, dentofacial injury prevention and management strategies, and for sports nutrition counseling, because we would really appreciate your efforts in assisting us to improve the oral health of athletes and reduce incidences of dentofacial injuries in sports. Thank you so much for listening to me. Signing off, this is Dr. Sneha Divekar, and I have my sports dentistry center in Karvenagar, Pune. And this is the website address of my course. And if anyone wants to take a picture of this, please feel free to do it. Thank you so much.
Thank you, Dr. Sneha. It was a very detailed presentation, wonderful presentation. We'll be going to the next speaker. So I would hope that we have few questions for Dr. Sneha, which will be completing at the end of the session. So I'll start with the next speaker and our last talk for the day.
No problem.
If you can stop your sharing, yeah.
Yes. I think I did, right?
I'll do it for you. No problem. Yeah. So I would like to now invite the next speaker, Dr. Aditya. Dr. Aditya, I think most sports medicine doctors know, because he is one of the most dynamic young speakers who have joined us, and he's been very active in all conferences, presenting in multiple conferences. So when I told him that we have got this, he jumped on it. So we have one small problem is that his internet is something has gone wrong with his internet, so he's not able to share. So I'll be sharing, and his video won't be available. But he'll be definitely speaking, and I'll be sharing like how we did earlier for Dr. Kyati and Dr. Kenjam. Aditya, you're there?
Yes, sir. Good afternoon. First of all of you, thank you to ISSEM committee. Special thanks to Dr. Siddharth for giving me this topic and a chance to speak upon it. As our society is growing, particularly in sports medicine is coming in demand, many new topics are coming up. Just like ma'am gave an excellent talk on this sports dentistry topic. So my topic would be on fibromyalgia. Yeah, can you start this? So my topic of speech today is fibromyalgia, the hidden syndrome. Okay. So myself, Dr. Aditya Sood, BBS and MD Sports Medicine. So I did my post graduation from VMMC Safdarjung Hospital, and after that I completed my 3 years of SRship. So I'm now running at a private clinic in Fasthouse, New Delhi. Okay. So fibromyalgia. So today we'll be starting this topic in the end. Okay. So next slide, please. Dr. Siddharth. So fibromyalgia is a hidden syndrome. So what it is about? Okay, so it is a disorder of chronic widespread tenderness and pain caused due to non-relaxation and inflammation of fascia. Okay, so the fascia which overlies in this disorder, the fascia will not relax. Okay, so since the fascia is not relaxing, there will be hard tender points. Now these hard tender points they won't allow muscle relaxation, so there will be disruption of mood. This disruption of mood leads to disruption of performance. Okay, so in sports person, since there is particular disruption of performance and low recovery, low mood, all this will fatigue syndrome like feature. The problem with this kind of pain is that it won't respond to the like NSAIDs, PCM, tramadol, or even muscle relaxants. They respond very poorly to them. Okay, next slide. What's the last? Next slide. Okay, you slipped. You slipped. You missed one slide. One slide behind. One slide behind is there.
Yeah, this is the next slide, Aditya.
Oh, okay. Yes. So, as you can see in the picture on the right side, I've shown you some tender points. So, most commonly, the patient will come to you with a complaint that I feel some knots, some hard structure that is lying upon my back tissue is not allowing me to relax. I'm having low mood. These are most of the complaints that a fibromyalgia patient will come to you, and most commonly, the females are more commonly affected by this. Now, this fibromyalgia will not just come with simple pain; it will come with low mood, it will come with low sleep, it will come with poor dental hygiene also sometimes, which ma'am had very well discussed. Sometimes patient may complain of abnormal symptoms like abnormal pain sensation, allodynia, hyperalgesia, okay, excessive sweating, and disordered reproductive function. A very commonly asked question to female athletes we must never miss. That if the menstrual disorder, if there is an underlying menstrual disorder also, that should never be missed, especially in case of female athletes who might commit a blunder on this. The next slide. So talking about epidemiology, females are more commonly affected, and more so it is more commonly seen in the Western population. A rough rate of around 3 to the epidemiology rate. I'm telling more about the US because in Indian scenario I didn't find any convincing data on this. So 3 to 5% in females and 0.8% in the males, and 5 to 6% females and 3.5% in males. So I have told the incidence in US and Europe respectively. The racial predisposition is not specific. In certain populations, they have inherent resilience to change or they have the capability to adapt according to the situation. Just like in some studies have shown that Chinese people are very resilient to change. So these people have good coping mechanisms against this disorder because a large part of this disorder is controlled by the mood. Okay. So sometimes you are not able to find a discrete diagnosis, and sometimes you may reject the patient saying, no, he's not of my type, he doesn't have any disease. And sometimes it is also called as a dustbin diagnosis because you are not able to decipher a clinical condition and you are not able to find out a discrete set of findings that explains all the symptoms. So sometimes it becomes a dilemma for everyone, for a diagnostician or clinician. So it's also called the dustbin diagnosis. Next slide. Next slide. So why females are more prone to this disorder? So females are more prone to this disorder because they have different type of processing system in the brain. Any stimulus which we give to your body is affected by two things. First, what is the type of stimulus? Second, how the brain interprets it. So in the females, it is seen that the coping mechanisms are not very good in most of the cases. That's why it can lead to fibromyalgia in them. More incidence of depression, anxiety, and stress is more common in them. And also, with the fluctuation of the phases of the menstrual cycle, the pain may also fluctuate. So this becomes even more problematic to manage. And also, what type of stimulus and how the brain is receiving the stimulus and how the brain is reacting to the stimulus is very difficult to decipher in this condition. And more so in females, because sometimes they may also overreact to the pain. So this makes it even more difficult to judge that what is causing the problem. Next slide. So talking about the etiology, so there are a number of factors that can affect this disorder. Taking the history etiological factors. So etiological factors are many, but to simplify, we have given this model of biopsychosocial model of disease. So as sports physicians, I request all my fellow doctors to take the history in these parameters. The problem with us doctors is that we are very good in biology part, but we may suffer in psychology and sociology a lot. So this psychological and sociological history should never be missed. Okay, so this can make you a very good clinician then in taking a very good comprehensive history, because most of the time the problem might not be the organic cause. It might be more related to stress, more related to psychology, and more related to the post socioeconomic condition of many of the athletes in the country. So talking about biological, what can you ask in biological history? Physical health, last menstrual period, more so in case of females, right? Also about training load, training volume, then talking about social environmental. What is the current socio-economic status? How much facilities they are getting? Any mental harassment, any verbal abuse by the team coaches, team staff, any threatening behavior by anyone? All these can display fibromyalgia. And talking about psychological factors, any depression, stress, anxiety, lack of performance, and discouragement by team members. So all this of the history should be very comprehensive. If you take a very good comprehensive history, most of the times you should be very easily able to clinch your diagnosis. Next slide. So talking about cell, I have tried to simplify some of your patterns which may explain the etiology of this disease. So there can be altered genes, female gender, I've already explained to you why. So sleep pattern, lack of good sleep can be, lack of non-refreshing sleep can be a very common presenting complaint with this. So take a good sleep history. I'm very thankful to Dr. Guru and Dr. Karma Ulka ma'am that they have been creating awareness in our ISSEM regarding why sleep is so much important in athletes. So taking a good sleep history. Trauma to tissues by injury by loading pattern. Is the athlete getting overloaded, overtrained, which we talk, and also stress-induced hypothalamic dysfunction. So stress itself, remember that the sympathetic chain releases in your hypothalamus and releases all your pituitary hormones. So if the stress also increases, the hypothalamus also comes under stress. So it stops releasing all your pituitary hormones and you may land up in hypogonadism-like condition, something which you will see in RED-S, earlier called as the female athlete trial. Age more than 60 years, some psychological factors like pain beliefs, a hypervigilant nature. Patient is overthinking about the pain, so that will further worsen your case. Talking about environmental factors, traumatic childhood experiences, media hype, ethnicity. Next slide. So talking about pathophysiology, one mechanism is altered pain processing. And due to this altered pain processing, there is also disorder of the balance amongst the neurotransmitters. Mostly they say that there is an increased concentration of substance P and glutamate, reduced serotonin, norepinephrine, and reduced opioid-induced pain modulation. So increase of substance P and glutamate will always lead to a dull, aching pain that is not responding to any medication. Serotonin and norepinephrine, if they reduce, patient will always have low mood. So he will never recover from pain also because he's not mentally satisfied. His mind is not under control. And also, we have read more about pain gate theory. So the pain gate theory works by releasing opioids. So opioid-induced pain modulation also reduces drastically, which further worsens the condition. Also, so if there is degeneration to the HPA axis, which I had already talked that the hypothalamus is related within the sympathetic system, right? So if there is a degeneration to the hypothalamic pituitary adrenal axis, so what it will do is it will reduce your cortisol, it will reduce your ACTH, and it will also reduce all your hormones, especially the growth hormone. So in athlete, when athlete trains, the body gains some good muscle mass, the body gains some fitness. All of this will be mediated by growth hormone. If you are hitting the gym maybe 2 or 3 days a week, your trainer always asks you, please sleep well and take good diet. Why? A good sleep is important to release a very important amount of growth hormone that causes very good growth of skeletal muscles. That's why sleep becomes even more important. So deregulated sleep cycle, cognitive impairment, and overexpression of pain in form of allodynia or hyperalgesia. Next slide. So what is that parallel processing? So the pain is not so much, but the brain is taking it differently. This is where fibromyalgia's cut starts. So the pain can be affected at a number of levels in your brain. First is first is a motor reflex, similar local motor reflex. Next can be, is it injurious or is it non-injurious? That is the discriminative function. Third is autonomic function or a reflex function. Now, in between this autonomic and the emotional motivational comes the role of brain and parallel pain processing. So if your brain is finding something normal, even obnoxious, you will always overreact to the stimulus. And if you overreact to stimulus so much, the body becomes hypersensitive. It creates a pain modifying behavior. So this pain modifying behavior will always lead to conditions like allodynia, hyperalgesia, a very common complaint with all fibromyalgia patients. And you will see this more accentuated in female athletes. So how does this parallel processing of pain in the cortex come? Okay, so first of all, we should understand how, where, and the pain is perceived. First of all, we should know that there is the central processing area in the brain that perceives the pain. It is the ventral posterolateral nucleus of the thalamus. So it tells where the pain is there. For example, if you touch my hand, I feel the pain. So who localizes the pain? The VPN nucleus. Similarly, there is a dorsal insular cortex. So dorsal insular cortex controls the type of sensation or type of reaction to pain. Is the pain irritating? Is the pain lancinating? Is the pain a simple one? Is the pain an irritating one? Similarly, there is an emotional reaction to pain. Sometimes you may wince with pain. Sometimes you may cry with pain. Sometimes you may even react aggressively to pain. So that is controlled by an emotional component. That is controlled by the anterior cingulate cortex. And not to forget the emotional circuit of your brain, which is commonly called as the limbic system of your brain or the Pappas circuit. So Pappas circuit controls two things. First of all, it controls your pain experience to pain. So in fibromyalgia, there can be triggers. There can be triggers. If the athlete had a traumatic event in which he fell upon the ground and felt a severe lancinating pain, and you try to create a similar maneuver in your laboratory, in your clinic, or in your setup, you will feel the similar type of pain even with the lower stimulus. Why? Because the body has created a memory and the patient is not able to come out of it. Something like a PTSD, near traumatic experience. So it creates that type of pain, the emotional response power. Next slide. So how does the stress leads to derangement of HPA axis? So whenever the body will come under stress, the hypothalamus will also come under stress. So hypothalamus is called as the master of the master gland. Why? Because it controls all hormones of the pituitary. So hypothalamus goes down, then hypothalamus breaks down, the pituitary breaks down. When pituitary breaks down, the secretion of ACTH will reduce. ACTH secretion reduce means the stress hormone cortisol goes down. Okay. So similarly, if your growth hormone that goes down, your muscle repair work, muscle repair function, and muscle recovery all will be delayed. If your LH and FSH they come down, your reproductive function will be compromised. This is what is the pathogenesis of a redness or the female athlete triad was called earlier, similar to what you will see in fibromyalgia also. So these conditions sometimes run parallel to each other also. So it is very important that you should know how to modulate or reduce stress. Next slide. So cycle of dysfunction. So there can be a triggering event. So what can cause the trigger? It can be genetic or it can be associated with sleep disorder. So what sleep disorder will do? It will increase the stress and it will lead to derangement of the HPA axis. The HPA axis will lead to hormonal deficiencies. Hormonal deficiencies disturbs your energy metabolism in the mitochondria. So what do you see? Mitochondria. If that doesn't recover, the cell doesn't recover well. Also, it may lead to GIT related disorders. Stress itself can lead. So, if you have experience in very much of your stressful conditions, you have a lot of acidity coming out. So, if the stress increases, your GI upset starts to happen. And when GI upset begins, everything goes out of control. If the stomach is not happy, your body can't be happy. You have to be simply be versed with that fact. Also, if there is a lot of stress in the body, your immune system that goes down badly. When your immune dysfunction happens, your stress hormones may become counterproductive for you. You may predispose yourself to infections that will further reduce your performance. And also, if the stress continues, it may lead to a hypercoagulability syndrome. The later events that may also affect circulation all over the body. So just one simple factor, control of stress and emotion. हाँ, so just 1 minute. So control of stress and emotions, that is just one simple factor that is controlling all this dysfunction in fibromyalgia and chronic fatigue syndrome. So you see, just lack of control of stress can produce so many precipitating factors. So in fibromyalgia, treating of the stress will become of paramount importance. Next slide. So talking about what is the role of central sensitization in case of fibromyalgia. So how will this signal begin? So first of all, whenever your body tissue or the skin is stimulated, so there will be sensory impulses from the dorsal root ganglion. So what it will do is there will be extracellular calcium and nitric oxide that diffuse into neurons and cause exaggerated release of substance P and glutamate. Substance P and glutamate cause a very annoying dull aching type of pain. So it becomes persistent. So when it becomes persistent, a pain signal will be sent to the brain from the dorsal horn. So all is happening here is that your body received a simple pain stimulus, but just because your excitatory neurotransmitters are more in number, the brain is receiving the amplified effect. Since the brain is receiving the amplified effect, it will create protective behaviors and protective maneuvers, something close to allodynia or a hyperalgesia, which is very common with a patient with a fibromyalgia. Even if you touch these patients, they may wince with pain like anything. Right? Just because the parallel pain processing circuits are overactive, they have become overreactive or overprotective. So this will further restrain. Okay, next slide. Talking about clinical presentation, what is the most common clinical presentation is stabbing pain. Patient will complain that I am feeling something like a knot or something like a band around my muscles. Also, patient will have a very low mood. Patient will be depressed, will be sad, or maybe under stress, anxiety. You can just see from the face that these people are under so much of stress. They are having a low mood. They are not able to sleep well, low sleep. And most of the patients, they will recall some traumatic event in the form of something that they were playing someday, they dislocated their shoulder, or they were playing for some time, they were getting treated at some center, but their pain relief was not coming up, and slowly their performance went down. So lack of recovery from injury will become another precipitating factor in these cases. And allodynia hyperalgesia, I've already explained you people. So we'll go to the next slide. Next slide. So how can an athlete come to you? The athlete will come to you with the following complaints mostly. My athletic performance is declining. One of the most common presentation. And since the athlete performance is declining, he will not be able to recover from injuries. He will, even if he recovers, he will get the same injury back in a few days or after 1 or 2 days, he'll re-pick up the same injury. And most important, not to be missed nowadays, redness. Very commonly, you will find these patients in fibromyalgia that they will have some part or one part of redness associated with them. It's very important that you don't miss out on redness. And thanks to VJSM that they have simplified the redness thing very easily, so you can see the red flag signs early and you can screen out the athlete. The main problem why redness goes unnoticed in the public is that there is lack of awareness that such type of disorder even exists. So it is more important as sports physicians that we ask these questions and we screen out such athletes very well. Next slide. So talking about the physical examination, so physical examination will reveal multiple trigger points or something like a band, something like tight bands around your muscle. So multiple tender point method can be defined by the location of the site. So to localize the site, you have to change positions. Some may be on the front, some may be on the back. And there is an order on how you can palpate the tender points and how much of the pressure is precipitating the pain. Sometimes it may come with just touching, sometimes with some gentle pressure, sometimes with some forced pressure. And according to that, you can rate it according to the VAS or the visual analog scale. Next slide. So this is the diagram which I've shown. So mostly what we and trigger points is mostly they are around the neck and the scapula, the most common site which I encounter. We also keep three control points so that the patient doesn't over exaggerate. It is very rare to find a trigger point around the forehead, so it is one of our control sites. And one other control site is the nail. In nail, you will never find a trigger point because it is the disorder affecting the fascia of the muscles, but not around the cuticle of the nail. So mostly where you will find the trigger points is around the trapezius, around the sternocleidomastoid, then around the trapezius, then around the scapular muscles, and then further going down towards the gluteus muscles, and then on the lateral epicondyles. And next slide. So in order to quantify that how much of pressure is producing pain, there's a device called as pressure algometer. In pressure algometer, you can apply the pressure with your hand and you can gauge and calculate the pressure and define that how much of a hard trigger point has been made. So just like I had told you in the physical examination that you have to first localize the point, change the and define the position, and define on how much pressure the pain is coming and how much of pain it is causing with the help of VAS to quantify it better. So the same work will be done by pressure algometry, and pressure algometry is a bit of an objective method because you measure the pressure and you define that how much of a hard trigger point you are seeing in the muscle. Next slide. To simplify the things, because fibromyalgia doesn't have any discrete symptoms that can be explained by one thing, the American College of Rheumatology created a diagnostic criteria. One of them is presence of multiple trigger points with the sites which I had already explained to you earlier. You should keep this chart with you whenever you find such patients so that you can define and classify these patients depending on their severity. So one of them is the trigger points. Second, you have to define about the symptom scoring. Do you feel any fatigue? Do you have any cognition or memory loss? And do you feel up with a non-refreshing sleep? Even if you don't have much time in your OPD settings, at least ask for a non-refreshing sleep in athlete or even in a common man. To ask about sleep, because one of the hints to early diagnosis of fibromyalgia will be disordered sleep. So depending on the severity of these 3 points, it can be no problem, it can be slight problem, it can be moderate problem, it can be severe problem. And also the last question is, during the past 6 months, have you had any following symptoms like cramping in the lower abdomen, depression or headache? If and further additional criteria which don't give you any score is question number 4 and 5. Have the symptoms in question 2 and 3 and widespread pain have been present at similar level for at least 3 months? So is the similar baseline coming for 3 months, but they don't add to your. So you define the trigger points, you define associated symptoms with stress or depression, and third, you define any depression or headache that is associated. So next slide. So what can be the complications if it remains untreated? Extreme allodynia. And it can also create substance abuse disorder because this pain will not respond to your conventional opioids. So an opioid substance use disorder may also develop secondarily. And since the patient is not able to function in his activity of daily living, a functional impairment pattern will come. And also it is associated with mood disorder. So severe depression and anxiety will develop as a complication, and patient may have disordered eating. He may develop a secondary eating disorder also. So patient may develop obesity and metabolic syndrome. Next slide. So what could be the differential diagnosis to this condition? It can be SLE, it can be multiple sclerosis, polymyalgia rheumatica, axial spondyloarthritis, thyroid disease, type 2 disease, anemia, and chronic fatigue syndrome. Most of them can be differentiated by the help of biomarkers. In case of fibromyalgia, you won't get the conventional biomarkers coming up positive. Just like rheumatoid factor won't be positive, anti-CCP won't be positive, anti-double strand DNA, anti-nuclear antibodies, they won't be positive. So Just by getting some good investigations, then you are able to exclude out the conditions. Then that's why, because in fibromyalgia you don't get your biomarkers also positive. That's why it was earlier called as cuspid diagnosis. Next slide. So now coming to the treatment and management of fibromyalgia. So first we will start with investigations. Next slide, sir. So first of all, get a CBC done. So CBC with DLC per se won't reveal any disorder, but just to rule out any other inflammatory conditions, you should get this test done. Vitamin D3 levels. Low vitamin D3 leads to low mood, high anxiety, and slow muscle recovery. So get vitamin D3 tested. Similar is with vitamin B12. Iron studies. In females, anemia can also lead to such factors. So a good iron study should be done, which should include TIBC, serum ferritin, and serum iron levels. Magnesium. Magnesium, if low, can lead to depression. Magnesium, if low, can lead to cramps. And it can also lead to hyperirritability, something which is very common in fibromyalgia. And talking about the ESR levels, in ESR, it will be increased, but it doesn't rule out other rheumatological conditions like polymyalgia rheumatica, your SLE, rheumatoid arthritis. Antipolymer antibody, a biomarker which can be positive in some cases of fibromyalgia, but it doesn't define fibromyalgia well because it has a sensitivity of only 50%. Next slide. Do do test your patients with a complete metabolic profile, which should include LFT, KFT, serum electrolyte, blood sugar, and thyroid, the bare minimum. Also test your patients, which I have not mentioned here, about RA factor, anti-CCP, anti-nuclear antibody, uh, anti-Smith antibody, or any other rheumatological markers you know of. You should test them to rule out other rheumatological disorders. EMG NCD. So what is the role of EMG and NCD? To check out active denervation patterns. If the pain that sometimes in some neuropathies, this type of pain may also develop. So to rule out neuropathies and myopathies, get EMG and NCD done. And heart rate variability testing on ECG. Today we had talked a lot about it on the overtraining syndrome part. So this is a recent advance just came up around maybe 5 months back, that they are saying that people who have a very much change in the heart rate variability as monitored on the ECG, these people are more prone to autonomic symptoms, which can include abnormal perception of pain, which can also include altered sleep pattern and a very poor recovery. In COVID, similar symptoms also came up and people landed up in chronic fatigue syndrome, where HRV is playing a diagnostic role, though the hard guidelines have not come up on how to use the HRV correctly, but they have found some correlation of HRV on ECG. HRV is a good area, and Dr. Barun has been an expert on this. I think he can explain us better about this. So talking about levels of neurotransmitters, reduce serotonin, reduce norepinephrine in the blood as measured indirectly by the metabolites in the urine. Next slide. So there are some scales which you can use. Most commonly is the fibromyalgia impact questionnaire and the physician health questionnaire for depression and generalized anxiety disorder. To gauge the level of psychological depth and trauma patient is undergoing, you should have one of your scales at your table at your disposal. Next slide. So the health assessment questionnaire, very commonly which you can use. In this, the patient we ask, depending upon the psychological stress he is in, depending upon the activities of daily living, which can be dressing and grooming, waking up from the bed, eating, walking, hygiene, preaching, gripping. So similar activities of daily living, if they are getting affected, this means the patient is very severely affected. Next slide. So similarly, there is a revised fibromyalgia impact questionnaire. So this is also similar to what the patient is experiencing. First in his activities of daily living, which can be brushing and combing, walking, preparing a meal, climb the stairs, change bed sheets, and further to simplify it, you can also ask the patients in doing your work how much you feel your pain or how much of low mood or low energy you are feeling. So these can be a few markers which you should have with you on your table where you can gauge the severity of psychological stress. If you are not able to keep printouts of such things, at least you should take some good psychological history about is he able to get up from the bed on time and is able to perform the activities of daily life. So, so taking a good history on the psychological part will also help you a lot. Next slide. Talking about psychometric testing, there are many psychometric scales which you can use on your table, just like the sickness impact profile, multidimensional pain inventory, and Minnesota multiphasic personality inventory. Next slide. So coming to the treatment of fibromyalgia. So first we took a good history. We gauged the psychological pain of the patient with the help of scales. So what about the treatment now? So there is a bad news that there is no permanent cure for the disease. Why? Because it's an altered pain processing. But that doesn't mean you can't control it. So using proper education, regular physical activity, and proper medications can ensure proper disease control. The most important thing which you should ensure as clinicians is that the patient actively participates in everything, which can be patient education, which can be encouraging him to do exercise, encouraging him to add physical activity in the routine, encouraging him to add meditation, encouraging him to use methods that de-stress his mind. So this is where your role as a clinician will come. Some methods which I have been commonly using in my clinic with my patients is the progressive muscle relaxation, visual imagery, pacing, and distraction. Next slide. So in talking about what the research shows in most of the randomized controlled trial, they say that if you combine exercise therapy with a educational or a psychological therapy, the results are definitely better in the short term, but yes, they don't improve the long-term outcomes because relapses become very common in these cases because fragile mood can be very common with them. Two things which make the most of the impact in these patients is if you are able to elevate the mood, if you are able to make the patient sleep well, you treat half of the disease already very well. And to make the areas better stimulate to stimulus or don't overreact to stimulus, role of modalities like deep brain stimulation, acupuncture, and TENS are also of a very good role. But remember, remember, in the entire treatment, there will be no replacement for four things, which we sports physicians should very much focus, and that is our strength from entire medical fraternity. Sleep, diet, exercise, and low stress. If you are able to focus on these four things, you become a very good clinician. Why? Because half of the prevention of disease and since non-communicable diseases are increasing so much, role of sports medicine will come up in the future, and these will be your four weapons. So these four weapons, you should be very well versed with all of them. If you are able to use these four weapons very well, you are able to treat your patients very well. Next slide. So the talking about the role of psychotherapy. Now, why psychotherapy becomes important is because in fibromyalgia, there will be associated mental disorder like stress, depression, anxiety, and they will be the patients who will might require some psychological drugs, something like an antidepressant, just like SSRI, SNRI, or a MAO inhibitor. But just giving an antidepressant won't solve the problem because the four pillars which I talked to you about, you need to correct all the four pillars. Then only you can give a complete treatment or you can give him some hope. But this doesn't mean that you don't treat the patient well. So combining antidepressants with CBT helps most of the patient and also relaxation training, imagery, and sleep hygiene. Next slide. So talking about how does how does imagery works? I've shown you a hypothetical situation in the left hand side on the slide. So talking about the thought that if the patient is so much depressed that I am a failure, I have no right to live, he will have a feeling that I'm hurt, I'm incompetent, I'm useless. And and what he does is he will try to withdraw himself or run away from the situation. But on the other hand, if you give him something like a distraction of thought, how does this work? So how you create a distraction of a running thought? You give him an alternate hypothesis. You say, if you fail once, it doesn't mean you have failed in life. Failure is also a part of learning. So if he's counseled well, and he's convinced that yes, failure doesn't mean that I have failed in life completely. And if he listens to you well, so Instead of having a negative behavior, he will develop some good feeling, just like a hopeful or a confident guy. And in the behavior, you feel your feeling, and also you encourage the athlete push harder, push stronger, and you may win next time. And a very important drug which I've shown you on the left hand side, duloxetine, this has worked as a wonder drug in most of our cases because it combines the advantage of serotonin and norepinephrine reuptake. It prevents the reuptake of both, so it has given very good results. And according to FDA, it is only one of the approved drugs that has shown promise in fibromyalgia treatment. Next slide. Skip. These are videos actually, they won't play, no? So talking about role of physical therapy. So role of physical therapy will come because there is tightness along the muscles, especially along the fascia. So doing a good exercise regime would be very important. But the main problem for physicians is what to prescribe, how to prescribe, and how much to prescribe. That is the question because people don't know how to quantify exercise. So you don't need to give so much in a single visit. Just ask them to start with light aerobic activity, something like swimming and cycling that increases their heart rate, that makes them feel good. Start with this. And once the patient starts feeling good, he develops confidence, he becomes regular for a few weeks, then eventually you can start physical therapy and resistance training with light therabands or light weights. This is how your progress should be there. Next
Aditya,
slide.
sorry, Aditya, can you fast forward because we have got another 5 minutes and then we are coming to the end of the session. That's why.
Okay,
Okay.
okay, we'll wind up. Most of it is done. Most of it is done.
Yeah.
Okay. Next slide. Uh, for physical therapy, it is important that it should be done under supervision initially. If the patient is doing well, then he can do it independently at home. And your role as a clinician will come that you should continuously encourage your patients. Your continuous encouragement can act as a very good factor in recovery. Next slide. Skip. Next. So talking about pharmacotherapy, analgesics like NSAIDs, tramadol, PCM, they won't help much. Even muscle relaxants practically don't help much. But there is good role of antidepressants. The only drug that has shown best promise is duloxetine, SNRI, serotonin norepinephrine reuptake inhibitor, followed by SSRI, followed by MAO inhibitors. Okay, but to act as an adjuvant, we are also using anti-anxiety drugs like vilazodone, trazodone, or buspirone to improve sleep quality. Next. Also, some hypnotic agents like zalpilone to involve more refreshing sleep have been used. Some anticonvulsant agents off-label like topiramate, oxcarbazepine have also been used. And a very important drug called as modafinil can be used for patients who have a work shift related disorder. Next. Remember, though duloxetine is a wonder drug that has shown very good promise, it may lead to a withdrawal syndrome, something like which can cause nightmares, confusion, agitation, irritability, depression. So increase the dose gradually, start in a low dose and withdraw very slowly in case of duloxetine because relapses will become very common. In talking about adverse effects, nausea, constipation, increased heart rate are some of the common side effects which patient will see, and agitation. Next slide. Now talking about the side effects of tricyclic antidepressants, since they have anticholinergic properties, dry mouth is common. They have a narrow therapeutic index, so they further can precipitate long QT syndrome. Coming to the next slide. So how can you improve sleep? So sleep disturbances become very common. So in order that how the patient is taking sleep, you can encourage the patients that they should maintain a sleep diary in which they should write about their sleep hygiene. It becomes very important in tracing about how the sleep pattern is going on. AFMC is doing a very good research on this. Dr. Guru, you can ask him anytime on this. So first of all, one should document the time at which patient goes to bed. What is the time of falling to sleep? Is he using any drugs or coffee? Is he using social media or gadgets before sleep? Are some of the questions that should be answered in the diary. Next slide. So these are some tips that will help you improve your sleep. First of all, reduce the room temperature. Keep your room dark as much as possible because darkness will induce melatonin that induces sleep. Use a sleep mask and avoid caffeine, avoid social media, avoid taking heavy meals before sleep. If you can do exercise in the evening, it will automatically produce a better sleep at night. But late night exercise should be avoided. Do it in the evening and take good rest at night. because a good exercise routine will always induce you a good sleep. And bright light exposure should be cut down, and try sleeping around 9 p.m. because that is the time when growth hormone is maximally started secreting until 3 p.m. 3 a.m. in the morning. It works in a pulsatile fashion to repair your muscles. Next slide. So improving about nutrition. Taking a good consultation with a nutritionist will very important. First of all, control the diet. Junk food should be completely thrown out of the pocket. That is very important. Take a fruit-based diet. Fruit which are rich in antioxidants. There is a good role of antioxidants like vitamin D, vitamin C, and vitamin E. Also, there is a good role of coenzyme Q10 and magnesium. Next. Also, supplements like vitamin B12, vitamin D, L-carnitine, and yes, BCAA will help to improve some recovery as it preserves some muscle mass and also keep the patient's mood up. Next. So these are some example of anti-inflammatory foods. Okay, the things that are junk food. Junk food reduces more fat and more inflammation. So eating a simple plant-based diet in most of the cases, which are mostly protein and nutrient rich, will help you to recover well. Next slide. Now talking about role of electrotherapy. In the electrotherapy, UST and TENS can be combined together so that they trace out the trigger points and break them simultaneously. Also, shockwave therapy has shown a very good promise because in shockwave, it gives continuous shocks and it opens up the band-like muscles. And when you, after doing the shockwave, if you apply a good tape, the patient feels a very good relief. And after that, you can start exercises in a short term. Use of dry needling and acupuncture, they break the trigger points, but they don't prevent them their reoccurrence. They could be broken at once, but their recurrence can be prevented only by the other methods. Next. So managing flare-ups, a very big headache to every clinician. So what could flare up fibromyalgia? First is infections, unaccustomed physical activity or untrained load, diet changes, diet changes, changes in mood, and starting of new medications. These are some factors. So try to rule out what is causing the flare up and try to treat the cause immediately. As soon as you cut out the cause, the more better outcome you can get. Next slide. So talking about long-term monitoring. So if you talk about long-term monitoring, so follow up with the patient will be very important. And the most important factor that describes your success in treating the patient is having a good report. Listen to your patient carefully in these cases. Then only you would be able to treat it. Giving two medications won't solve the problem. So maintaining a good repo, and with a good repo, compliance should come up. The patient should be able to follow you, what you are trying to explain him. So role of good counseling. And if you have a psychotherapist at your disposal, kindly engage him in this service. Next. So how to manage athletes with fibromyalgia? So to manage athletes with fibromyalgia, the most commonly thing which we fear the most is redness. So taking a good menstrual history and taking history of joint pain or stress fractures will become very important. Unaccustomed training load or a history of verbal, physical abuse from the teammates, from the coaches, from the support staff would be very important because these factors are overlooked. And according to BJSM, the most common factor why redness becomes so common in female athletes is that there is a preoccupation with body image. That if you are leaner, you become stronger, but that's not completely true. That's not completely true. Okay, going to the next slide. So these are some examples on, I've taken it from the BJSM, that there can be some red flags, there can be some yellow flags, there can be some green flags. Talking about red flags is if the patient has an eating disorders, he has suicidal tendencies, the athlete is continuously losing weight, and athlete has continuous stress fracture, it's a warning sign. Withdraw him from the game immediately. And athlete has developed ECG related findings, withdraw the athlete. And there can be some yellow flag signs which need moderate attention. Moderate attention, which can be substantial weight loss around 5 to 10%. Okay, the growth parameters are going down. Okay, the menstrual cycle is getting altered but not frequently, and the reduced bone mineral density. So you should keep these charts with you and try to tick the boxes as much as possible so you classify your athlete. Next slide. So return to play guidelines. I will cut short this because I've explained you one example of what you do in a patient with concussion. Similar protocol you should follow in cases of fibromyalgia because it is more about how much you manage the load well. So in the first phase, you can ask the complete cognitive rest. Eventually, you add light aerobic activities, then add light strengthening activities, then add light skill related activities, then agility, and then return to play. Next slide. So coming to the conclusions of fibromyalgia is a very tricky condition that can itself become difficult to diagnose because there can be no discrete symptoms. So the most important factor which I'm stressing a lot is kindly listen to your patient with empathy, give him or her the time to speak well. If he doesn't speak well, if he doesn't open up with you, there will be no good result with the patient. So it also has no permanent cure, but only a combination of things can keep the disease under control. And for athletes, it is important that you manage training load, energy needs, and balancing of sleep. Okay, so I end my talk. If there are any questions, you can type in the chat box or you can type in the. So, so it is important that fibromyalgia is a tricky condition and a hidden syndrome because lack of good counseling and a multidisciplinary approach team is needed. So fibromyalgia can't be managed by one person, but a group of persons working together in the same direction. That's why a multidisciplinary approach is needed more so in sports teams. Okay, so I'm open to questions if I can answer them.
Thank you, Dr. Aditya, for a wonderful, detailed talk on fibromyalgia. It's been fibromyalgia is a very hidden condition. Usually, I see it more mainly in a lot of regular housewives. You know, they come with pains and aches, and usually we treat it as some kind of just triggers. It is quite painful. They get depressed because of that. So it has to be a multidisciplinary work which we have to do. I've got few questions. Dr. Sneha, you're there, Dr. Sneha?
Yes, I'm.
Yeah, so Dr. Sneha, I'll ask one question, which was we have two questions which was asked. One was, what is your take on sports drinks and supplements on dental health?
Yes, it's an interesting question. In fact, I recently just gave a presentation regarding this very topic at a sports nutrition summit. So there are basically two things regarding sports drinks and supplements: the carbohydrate content and the acidic content of the sports drink. So yeah, the carbohydrate content keeps varying, keeps changing. The main thing that we have to take care here is, we have to give some certain tips to the athlete while consuming the sports drink. First, two to three things mainly which I would like to convey to all sports professionals: please tell, as far as possible, try to consume them if it is really required. Second thing, even if they do need to have the sports drink, they should take it with a straw, and not swish it in the mouth. So as far as possible, avoid contact with the teeth and the oral cavity. Second thing, try to have them chilled, not warm, because they can be more erosive. And most important, we call it a two bottle method. After every drinking, after every time, when the athlete drinks has a sports drink, he must gargle his mouth. He or she, they must gargle their mouth with water. So see, all these things are, see, because we cannot completely stop them from having sports drinks, because certain type of athletes do need that for their, if they're practicing for more than 2 hours or 3 hours. So we need to tell them such kind of modifications that it will minimize the effect on their oral cavity. And regarding the acidic content of the sports drink, again, swishing through the mouth has to be avoided. And there are certain kind of CPP, ACP. There is a casein phosphopeptide is what we call. So now some studies are revealing that 0.125% of the CPP ACP in the sports drink will dramatically reduce the occurrence of dental erosion. So I think now some studies have come out with this, and I think they are trying to incorporate this content in certain sports drinks. So I think you and me, we all should research on this. This topic needs further research, and what type of sports drink we should recommend the athlete. We should really kind of sit down and really make some good charts about it.
Yeah, thank you, Dr. Sneha. I'll go to Dr. Kyati since we are short on time. I'll just give one question each. Dr. Kyati, you're there? Hello, Dr.
Hello,
Kyati?
can you
Yeah,
hear me? Yeah.
yeah, I can hear you. So one question which was asked is, does India, India Athletic Association or India, in general, has any specific rules which they have created for transgenders in sports?
Uh, can you repeat the question? Does India have any?
Does India, as because till now, what all the rules for transgender in sports has been defined by the International Athletic Association as well as by FINA, all the international bodies. Does India have any specific rules for transgender in sports? Do they have any specific rules which they have created?
The Athletic Federation of India also follows the rules that are provided by World Athletics. So we have certain guidelines as to how we will implement those guidelines, but we don't have guidelines of our own as such. Uh, I think maybe in the near future, even at the national meets, because some of our national meets also are world ranking championships. So when the rule applies to all the world ranking championships, then it applies to some of our national meets as well. So I think in due time we will have our own, but until then we follow whatever World Athletics lays down the guidelines, and whatever is required of the athletes who make the Indian team is done via those guidelines.
Yeah, thank you. Aditya, you're there. One last question from
Yes,
you.
I'm there. I'm there.
Yeah, yeah. This is one question. Since most fibromyalgia patients, general population, they go and meet the rheumatologist. Rheumatology department has got one of the highest, and general medicine have got one of the highest. They get a lot of fibromyalgia cases. So, is there any specific? I mean, I know it is a mostly a negative diagnosis. You understood a negative diagnosis to come to fibromyalgia, but is there any specific blood tests which can differentiate fibromyalgia, which we can do? That's the question asked. Any specific test is there, blood test is there for fibromyalgia as such? Like in dermatology we do the ESR, ANA and everything. For fibromyalgia, is there anything such?
For fibromyalgia per se, there are no specific tests because the thing is that it is mostly like a diagnosis of exclusion. Anti-polymer antibodies is one which is positive in 50% cases and to some extent is bit specific. And reduced levels of neurotransmitters, which is indirectly measured in the urine for serotonin and norepinephrine, can be few of the markers, but even they are not very discrete markers. Now, why the term dustbin diagnosis was coined was because there are no discrete findings from the lab or from the clinical examination that pinpoint that this is fibromyalgia. So this is where one of the common complaints come. And one more important thing is that what I have seen with most of the rheumatologists also, that lack of empathy. That patient don't feel negative from the disease itself, but the behavior of the clinicians itself sometimes can make them feel negative. So our role in positive encouragement becomes even more. Because as per the ACR criteria also, they have also not defined any markers that are very specific to fibromyalgia. Maybe in the near future, we may be able to find some. But yes, one good research that has been proving very fruitful with fibromyalgia is use of heart rate variability and autonomic testing. Because it predicts the onset of chronic fatigue syndrome early in the patient. And more so in athletes, its role will come up. And Dr. Barun is one of the experts in that. I think he can explain us better about that.
Thank you, Aditya. Now, since we have completed all our subjects, all our talks, I'll go to our most treasured person here, Dr. Kiran Kulkarni, who will be giving our vote of thanks and will be telling everything what is summarized, so that we end this thing with no other better person than Dr. Kiran. On to you, Dr. Kiran.
Thank you, Siddharth. Right from morning, you have been fantastic, moderating all the. Can you hear me? Am I audible? and you have been doing a fantastic
Yeah,
job.
yes, sir. Yes, sir. You're audible. You're audible, sir. So I had muted
Okay.
myself.
Yeah. Respected President Dr. Barun Sharma and most loved Secretary of our ISSEM, Dr. Siddharth, who has been on top of the dais today the whole day. All executive members of ISSEM, Indian Society for Sports and Exercise Medicine, and most important, the esteemed speakers who have been fantastic the whole day. Dr. Praveen, Dr. Chetan, Dr. Anup Krishnan, Dr. Amol Patil, Dr. Khyati, Dr. Deepak Babu, Dr. Sneha, Dr. Aditya Sood, and of course my very dear friend Dr. Kenjo. So it was a fantastic online meeting today, and after a long time we had this organized by ISSEM. Like in a dissemination, most important, it was like a dissemination of knowledge of world class. It was of course world class knowledge to all the delegates, and also thank all the delegates who have attended to this seminar. And most important, I would like to announce two things in the next few months. That is, we are going to have a 2-day national conference of Indian Society of Sports and Exercise Medicine, ISSEM Con. And the probable dates are 22nd and 23rd of November 2024. Please mark these 2 dates, 22nd and 23rd of November. And most important, the pre-conference congress will be of 3 days. Usually it will be otherwise, but we'll be having 3 days because sports medicine, I feel, is more of the practical oriented specialty than a theoretical. And in this pre-conference workshop, that would be from 19 to 21st November. Okay. So the conference will be from 19 to 23. Please mark your dates. Almost a 5 days conference, because it will be quite elaborate and quite fantastic. And more than anything else, we will be including the subjects of biomechanical movements and gait analysis, then musculoskeletal ultrasonography and injection techniques, then fitness evaluation, exercise testing, and of course we'll be having a doping control and sample collection procedure. And this time we'll be having both blood as well as urine sample collection procedure also. Exercise is medicine also will be our next important task, and will be soon we'll be announcing something great about exercise medicine. And of course, very important is about exercise emergency medicine in sports. Okay, so this is one of the most important part of ISSEM, and the other one is we'll also be conducting elections, because ISSEM now we are having the present team is almost, we have completed about 4 years since 2019 after our registration of ISSEM. So now it is high time that young staff and experienced like seniors all join together and continue on the good work of what this present team has done. So general body will decide, and on that we will go ahead with the elections. Last but not the least, thank you all speakers and all delegates, without whom this seminar would have been incomplete. We hope to meet again with with newer topics and newer dimensions in sports medicine and sports science. So thank you one and all, and hope we all join hands to do some good work together in the field of sports medicine. And let us not
Sir, one small thing. You have not yet announced the venue, sir. Venue was missing.
Yeah, that will be last. I'm just last but not the least. Okay, the venue will be in Banaras Hindu University, that is Medical College, Varanasi. So Dr. Barun Sharma will be hosting the conference. Okay, so that was like the last I wanted to announce. Thank you, anyways. Okay, so thank you one and all. Have a great evening. Thank you.
Thank you for attending. I'll be closing the session. Thank you. Any questions can be put in the chat group or can be put in the group. Our panelists are always available. They will answer to all the questions. Thank you once again for attending, everyone. Thank you.
Thank you, Dr. Siddharth. Thank you very much.